All right. While we wait for the rest of the panelists to join us, I'm going to go ahead and get started. Thank you all so much for joining us here today, and thank you, Americans for Safe Access, for having us. Today, we're going to be talking about regulating affordable and accessible medicine. I'm your moderator for this panel. I'm Zhang. I'm the state's cannabis policy reporter for Politico. So over the past couple of decades, we've seen a huge shift in medical cannabis laws across the country and really across the world. 36 states now have reformed their laws to allow medical cannabis programs. We have bills to legalize medical cannabis in states like Alabama and Nebraska, Texas. The House just this week passed a bill to expand their compassionate use program. And, I do expect to see some ballot initiatives this issue next year. At the same time, as many of you guys know, the federal state conflict in cannabis laws causes, accessibility and affordability problems, mostly because of the federal illegality prevents medical insurers from covering medical products. But it's not just the sort of federal state conflict in cannabis laws. How different states choose to regulate cannabis also has a big impact on how accessible and how affordable these products are for patients. So I'm so happy to be joined today by our esteemed panel. We have Chaney Bourlon-Hilterbran, who is chair of the 411 Affordability Program. We have Chaney Turner, the Cannabis Regulatory Commissioner for the State of Oakland. And we also have Philippe, who is the Vice President of Patient Research and Access at Public. So thank you all for being here today. To start off, I was wondering if Amy, you could give us a little bit of background on your role at Leaf 411 and how you see different programs addressing the issue of accessibility and affordability. Who's doing it right? Who's doing it wrong? What can we learn from the pitfalls of certain programs?
Oh, Amy, you're on stage. Just unmute your mic and your video.
Sorry, folks. Please bear with us as we sort out some technical issues. So while we wait for Amy to join us, I want to keep it moving because I know we have a limited amount of time here today. Chaney, could you tell us a little bit more about SB 34 in California? I know that the state had sunsetted its original compassionate care program, that it was the first in the country to be legalized in 1996. And SB 34 basically created a voluntary compassionate care program. What's the status of that? Are a lot of places participating, and what can be done to, further open up access and affordability for patients? You're on mute.
Sorry, we're going to get this together, y'all. Thanks for being patient with us. Well, as most know, under the medical 215, dispensaries, were able to, gift medicine to patients, especially patients dealing with PTSD and, other.
Hello, everybody. I don't know if you can hear me, but to answer the question about affordability, we certainly have seen limited access as well as lack of affordability pre-COVID and certainly during COVID. And hopefully we can start integrating access into elements that we haven't thought about before, such as inclusion for insurance to pay for medical cannabis.
Thanks, Amy. And I think, Chaney, why don't you go ahead and finish what you're saying?
Yeah, sure. And yeah, and everything that Amy was saying is definitely important in regards to insurance. Um, but yeah, under 215, dispensaries were able to gift medicine to patients, dealing with certain
We've been
ailments.
working with
And
what's called the affordability
oh,
programs, with works with hemp, CBD, and cannabis companies to supply low or discounted or even free medicine to patients who fall underneath certain financial guidelines. Obviously, we're also taking into consideration people that have been impacted by COVID. We're working with numerous nonprofits and have just expanded to include non-cannabis nonprofits so that we can offer cannabis patients elements that would help them, for example, items that are free that are not cannabis related. Legislation that's being passed currently is really multifaceted, and we need to make sure and keep a focus on the fact that priority lies in what's going to come as we continue to expand medicinal access to cannabis. Priorities certainly lie with us getting approval and protocol passed so that insurance companies can cover medicine, and certainly with the Safe Cannabis Banking Act, we can look at expansion for that for our medical patients.
Thank you, Amy. Sorry, Chaney. SB
oh,
46, go
it's
ahead.
okay. We like I said, we're gonna get it together. And so yeah, 215. Um, uh, being able to give medicine, to patients, but it's also important for people to understand that like none of that would have been possible if it wasn't for advocacy in the beginning, which was led, by Dennis Perone and Brownie Mary and many others here in the Bay Area that really took a radical stance in providing medicine to those
We're very
who needed
excited
it.
about the
And
continuing
oh,
access and the
Amy, oh,
acceptance of
Amy,
cannabis as a
I don't know if she can hear.
medicine, and hope that people can understand that not all medical programs are the same. We certainly need to have a understanding of the same type of language so that patients don't have to vary their treatment from state to state as well.
All good. I don't know if she can hear us or not on the other end. But yeah, if it wasn't for radical advocacy and activism, and unfortunately with 64 passing, that kind of sunset the compassionate care program, which really dismantled a lot of the work that people did for medical legalization, which led to us, even having recreational. And so advocates, put pressure, on the state, and we have SB 34, but it's still, uh, although we have it, it still isn't enough. We need more, and it puts pressure, on dispensaries too, who want to, gift medical cannabis, but have to deal with the overtaxation and like Amy mentioned, safe banking and different things. So we don't even have enough dispensaries participating to where we can get medicine to patients, and then dealing with the entire track and trace. But fortunately, again, it boils down to the people who've been impacted, the patients, low income people, veterans, right, who really need this program. So you do have compassionate programs here in the Bay Area. There's one that's called Black Canna Joy that focuses on providing free medicine to Black people and people of color who are dealing with PTSD, stress, COVID, and other medical conditions. Sweet Leaf has been around for a long time and still leading advocacy around SB 34 as well. And hopefully down the line, more manufacturers can be included in participating in the program.
Thanks, Chaney. Philippe, I'm going to head to you. Could you tell us a little bit about the state of patient access in Canada? Give us a little bit of the lay of the land of the sort of federal, provincial, local regulations, and what can we in the U.S. learn from the Canadian model?
Sure. Canada's benefited from having a federal medical cannabis program since 2001. It didn't come about because any political party wanted to do something compassionate for Canadians. It really came about because of a court order that recognized the constitutional rights of patients in Canada to access medical cannabis without arrest and prosecution. But just like in the US, cost continues to be an obstacle to access. Despite having a socialized medical insurance system here in Canada where most medical treatments are covered, medical cannabis for most patients in Canada is still not covered. And so patients are still left in the position in some cases of choosing between accessing or paying for their rent or paying for groceries or paying for their medical cannabis. There has been some progress, mind you. The federal government does cover the cost of medical cannabis for all police and military veterans here in Canada through Veterans Affairs Canada. And it's certainly something that I'm working with American regulators on trying to get for American veterans as well. And on top of that, we've seen an increase in private payer coverage for medical cannabis over the last few years here in Canada as well. But ultimately, we're still a long way off from other jurisdictions such as Germany and Europe, where all medical cannabis is covered through their socialized medicine system. So we've still got a long way to go in order to ensure that patient needs are met when it comes to accessing medical cannabis. And some of the work that I'm doing is gathering the information and data and research on how medical cannabis reduces healthcare utility overall. So patients who use medical cannabis reduce their use of prescription drugs, but also reduce ER visits, doctor's visits, etc. And I think that when all that data is gathered, we're going to see that covering the cost of medical cannabis actually leads to cost reductions because of lower healthcare utility by patients. And I think that's going to prove very convincing in Canada and the US and internationally, and encourage the cost coverage for patients.
Yeah, and by and large, most of the blue states here in the US have legalized medical cannabis and adult use cannabis. So the bills we're seeing moving forward right now are really in a lot of pretty conservative states. And a lot of these proposals are pretty restrictive. They don't allow flower, or they, tax medical cannabis. Chaney, do you have any thoughts on how these policy proposals impact patient accessibility and affordability?
It impacts patients a lot, especially lower income and patients of color. Cannabis is highly overtaxed. It's ridiculous of how it's taxed, which goes to show that the federal government really doesn't see it as a healing medicine. They're still treating it as a drug that they're expecting to cash in on all of these dollars. And I am so grateful that we have people in place that's continuing to advocate for it. Voting is voting for legalization is easy, but it's the continued work that's after. I personally did not vote for 64 because of all of the flaws. Of course, the compassionate care and the lack of equity, and the tax. When it's created from a capitalism lens, it doesn't benefit the people. And again, we would not have any of this if it was not for people advocating on the rights of patients. And I feel that we are losing sight of why this was started, in the first place. And it should always be around centering, the patients, and of course, those who have been mostly impacted by the drug war.
Yeah, and I, if I could add to that, I think that there's real concern as we look at the U.S. now, looking at federal regulations, that there's going to be desire at the federal level to overtax cannabis products. And in Canada, we've seen that happen, so that we've put on excise taxes, otherwise known as sin taxes, on cannabis products, not just at the recreational level, but also at the medical level. And in fact, there are a number of provinces in Canada, like British Columbia, where I live, where on top of the excise tax, we have a 20% tax that's quite recent added to vaporizer cannabis products. As a result of that, vape products are taxed at 43% here in British Columbia, including those who are using them for medical reasons. Whereas, of course, the black market is not taxed. So we're actually disincentivizing people from moving from unregulated illicit products to the illicit regulated products right now. And it's a huge issue, particularly when you consider the public health benefits of shifting people over not only from smoking to vaporization, but also from drinking alcohol to, say, using cannabis instead, which of course leads to public health benefits. So as it stands right now, and it's funny, I just had a meeting with legislators on this morning in Canada. Cannabis vaporizers are the most highly taxed consumable in Canada. The only thing taxed more is oil and gasoline, but even alcohol and tobacco is taxed at about 25%. So at 43%, cannabis vape products are the most highly taxed consumer product in Canada. And certainly I would hope the US would avoid making the same mistake.
Wow.
I highly doubt it. Just to, add on to that, they're going to fast track legalization on the federal level for the economy to recover because of COVID. And so that's my personal opinion. But again, the overtaxation is a safety issue. As we all witnessed, 2 years ago, or not even 2 years ago, the vaping crisis that happened, nationwide, with people, receiving vapes that have vitamin E oil and all kinds of other chemicals. And so taxation, it not only does not provide, access for patients, but it's also a safety issue, because people will be forced to manufacture products underground using whatever type of products and chemicals that they want, and people will buy because it's affordable. If we want to get the tax revenue and keep people healthy, we have to meet folks where they are, and the exuberant taxes that we're seeing here and also in Canada is ridiculous.
Yeah. I just want to remind everyone here that we're going to have audience Q&A momentarily. So if you have any questions for the panelists, please enter them into the Q&A box. And while we wait for any questions, I am curious about what you guys think about what is going on at the federal level. What has to happen at the federal level in order for medical cannabis in the US to be more accessible and more affordable for patients?
I think if in looking at the Canadian experience, we need to make sure that the federal regulators see the cannabis industry for what it is, which is an amazing social justice effort in order to stop criminalizing otherwise non-criminal behavior, a community economic development effort in order to create good jobs and a good economy, and moving the cannabis industry from the gray and black market onto a legitimate industry, but at the same time not seeing this as a cash cow, where you can impose sin tax upon sin tax in order to draw tax revenue. I don't think anyone would argue that cannabis products, particularly at the recreational level, should not be taxed, but they shouldn't be overtaxed to the point where consumers are suffering or the black market continues to thrive. And that's certainly part of what we're seeing here in Canada right now.
Right. And To answer your question, I think we definitely need to pay attention to the amendments that were made in the MORE Act. Some of them are very problematic and don't, favor the work that's being done on the on the equity side, especially when it comes to expungement and for folks with prior convictions to be able to, um, secure, a license. And just going back to what Philippe said about the taxation, we have to be sure that we center communities that suffer trauma as well. When we're talking about medicine and safe access, right? People who are from communities that have high crime and violence rates. Um, uh, there was a study that shows that Black youth of a certain age actually have higher PTSD than certain veterans. And so, by keeping it affordable, we are making sure that all people who have suffered traumatic experience, people who have suffered, violence, people who have been shot, gunshot victims, and victims of sexual assault are included in those conversations when we're discussing access as well.
I would also make sure that everyone understands if we wholly legalize cannabis and remove it from the Controlled Substances Act, that does not mean that it is an open forum and open access to patients. Indeed, it could be degradatory to the medical patients. So we need to make sure and educate, indeed, that the recreational aspect and industry of the plant does not equal accessibility and quality medicine for patients, especially pediatric patients. We need to make sure and prioritize that as we move forward with ending prohibition.
Yeah, that's a great point, Amy. I mean, it reminds me of what's going on in Maine right now, where there are a lot of medical cannabis caregivers there, and they're objecting to the adult use regs because the medical marijuana regulator wants to align the medical program with the adult use model, and that seems like it's going to be really burdensome, especially for like the smaller businesses. So in some states, definitely adult use legalization has had a negative impact on the medical programs. I guess, Philippe, what else can we learn from other states, other countries and their medical programs? And what can the US do? Because I feel like federal regulators here are always saying, well, we can't do it because of the, Narcotics UN Drug Convention, but there are other countries that are party to that convention that have federal medical cannabis programs. What can we learn from them in terms of how the federal government here can approach this?
Sure. Two things I would mention. I mean, I think that the country that's best figured out access so far is Germany in covering the full cost of medical cannabis to patients. Now, there's still hoops to jump through. Doctors have to be taught how to fill out those applications in Germany to send to the insurers in order to make sure that insurance coverage kicks in. And there is a limit in the conditions that are covered. So this is not a blanket coverage by any means. There's still obstacles to access. I think when I look more at the Canadian and US system, what we can really learn, and which has been an exciting development here in Canada in the last few years, is that private payers are now starting to, in fact, every major private insurer in Canada has some kind of a cannabis add-on that you can add on now for your employer coverage. So if you're a government employee or you're work at a university or otherwise, and you have a private insurance program, you can actually lobby them to add medical cannabis coverage to the cost of that program. And for a long time, that's been part of the work that I've been doing, is trying to expand private payer coverage as a prelude to public payer coverage for cannabis. And initially, the insurers would say, it's not an approved medicine, therefore we can't add this. And it would shut down discussions right away. But what we've seen over the last few years is that employers and employees are demanding this coverage. And I have to say that objection has completely disappeared. So for my American counterparts, when you're meeting with those major insurers at the state or federal level, and they say, well, this isn't an approved medicine, we've only got Sativex or Epidiolex as an approved cannabis medicine in the US. Don't be dissuaded by that, because ultimately you can create enough pressure in a competitive insurance environment where those insurance companies will feel the need to create cannabis coverage in order to not lose those major employer programs. So I just want to say that, I think that it is within reach in the US, as soon as medical cannabis gets covered at the federal level, to start getting insurance coverage for medical cannabis. And of course, the research that myself and others are producing are showing that when patients use medical cannabis, they reduce their use of opioids, of SSRIs, and other major classes of drug, non-opioid pain medications, et cetera, and that there can be cost savings associated with covering the cost of medical cannabis as a result. So I think all of that should really encourage American activists who are working in this space to work with the insurance industry to make sure that cost coverage is forthcoming.
Gotcha.
On a personal note, to say our son, prior to cannabis, was on $7,000 a month of pharmaceutical prescriptions that did not stop his seizures, that the insurance had to cover. Now he consumes less than $500 worth of cannabis medicine a month that we pay out of pocket, but it incurs no cost to the insurance company at all. And certainly now he lives with months with no seizures when the pharmaceuticals never stop the seizures.
Yeah, and there are other conditions such as GI issues, which come with prescriptions to very expensive biologics that can benefit from the use of THC and CBD instead, and with maybe fewer side effects. So it can actually lower the cost of a lot of different treatment options in some cases.
Mm-hmm. Just want to get to this question from the chat. Do you guys think that allowing for more collective grow sites would help?
I do. Some people just are not in a position or location or have the knowledge to be able to grow, and to be able to have collective or co-op, just more flexibility in grow sites, any kind of expansion of accessibility and opportunity, I think would be helpful, especially as we learn more and more about the opportunities for patients.
Yeah, I think that joining together and allowing patients to join together to benefit not just from the cost savings of collective growing, but also the psychological benefits of being able to grow your own medicine is a big part of what should happen. In Canada, patients have long had the right to grow their own cannabis. Most choose not to or are unable to for different circumstances, but I think that right continues to be important. And I also want to mention that, it's also the purview of private companies to lower the cost of medical cannabis. And at Tilray, we offer up to a 25% discount, for example, for low-income patients in Canada who can't afford the cost of cannabis. Still more needs to be done through private and public insurers, but private companies can play a share as well and do their part in lowering the cost to ensure access to patients who could benefit from the use.
Chaney, anything to add about collective grows?
I'm all for collectives. I believe that, it provides more access for people who might not have the resources. And with everything going on with cannabis being so overpriced, and from a health perspective, I just think it's much better. It's healthier to grow your own food, and so of course, growing your own cannabis, what you're putting, in your body, how, it was grown. And before the, over commercialization of cannabis, people was able to have a better relationship. You knew where your medicine was coming from. And dispensaries, or people on the legacy side had those relationships. So I think collective co-ops would bring us back to
All right. Thank you all so much. That's all we have time for today. Thank you to the audience for bearing with our technical difficulties. And I really appreciate all of the panelists for sharing their insights.
Thank you. Thank you for the invite.
Thanks,
Thank
Mona.
you so
And
much.
thank you all so much. It was a pleasure to be here, and keep up the great work, everyone.
Right.
All right.